program at MSU Billings. And Dr. Diede has been the BYU program director for the undergraduate athletic training program for 14 years. Mike has been involved in various athletic training committees and organizations at the national, regional, and state levels. And Mike loves the outdoors and spending time with his family. So let's welcome Mike. Dr. Diede.
Thank you, appreciate that. I do, yeah, these meetings drive me crazy because I don't get outside near enough. I've got to be outside. Go a little crazy. All right, so no disclosures for me, and I'm going to invert this just a little bit and park on the objectives here for a second and just stop and see if there's any questions. So I've given this talk was also given in part. I've improved upon it some from the NATA last year. Also gave it at the Big Sky meeting, and it's what is it, 4:40. So I can get out of here pretty quick. But do you have any questions, like right from the beginning, about reduction of dislocations that are on your mind? We can just have a discussion starting there. I mean, I have plenty to say. But if you have some questions, then we can start right there and go. So the objectives, and stop me anytime. I'm completely okay with you hopping up or raising a hand and stopping me. So let's do that as well. So here's some objectives, but they break down to kind of 2 or maybe 3 different areas. One is, I different for this talk than the other one is I did look up some of the licensure laws, so I want to spend just a little bit of time talking about that. Not a ton, because it's mostly about the techniques of reduction. And I want to kind of distinguish what we can do and maybe not do, or what we should and shouldn't do, and what are the appropriate techniques for the main joints. But I'll kind of go through the positions as stated in the position statement, try to stay as true to that as I can with the experience that I've had. And then the other is I'll talk about, just one slide, but I'll talk about a study that Cynthia Wright and I did to find out what people are doing in practice, which I think is really interesting and will change here now as we've had as a position statement come out, and then we're communicating with our physicians more and so forth. So that's kind of my objectives there. Okay, so there's some resources here that I always talk about because I think that they're important to think about and have. This clinical procedures book, if you don't have that, you should probably get that. It covers everything that our medical professionals, physicians do pretty much. I mean, specialty surgeries and so forth aren't in there, but it's pretty much in there. We have a few emergency care books, kind of old and new in there. And then really the place you're going to find things, which you can find right now. I mean, some of you are at your computers looking up Kevin's talk. You're welcome to look up the position statement right now and look at it, or Cynthia Wright's article on dislocations of the 3 main joints that we do. Or just YouTube. I don't have any videos here like Kevin does. I wasn't as brave as him to put videos on. But if you just Google dislocations, 1,000 will come up, right? 1,000 different painful looking dislocation reduction techniques that sometimes take way too long, mostly in the emergency room. But anyway, there are a few sources we need to have, and we have some resources in athletic training that talk about techniques. In the past, if you're old like me, you didn't have that. The old emergency books all said, just pack it up and go, right? Pack it up and refer. So in looking at these resources, the key thing to this is you'll have to decide what it is that you're comfortable with doing and not doing. And I was always, I don't know from where, but just kind of always comfortable giving these a try. I mean, to me having a doctor at my high school in Tucson, and then after I had a doctor who encouraged me to, put it back. Why would we keep them in pain? So I've always been a little, what we would call aggressive about this, or maybe outside the scope of practice, prior to license laws too. So I kind of had that going. So I've been kind of aggressive over this over time. Here's this a review of some articles that are in my reference list as well. There's kind of groups of people that work on various dislocations. Most of them clinical, most of them in the emergency department. And so one thing that we do need is we need reports, we need good notes, good assessment, good coverage, and heck, have somebody that's not doing anything better take out a phone and record what you do. I know that's risky always, but especially on a relocation, it'd be good to have documented like video evidence of what's going on as reductions occur in specific to the athletic training setting. So here's my one slide. I'm going to talk about this study that Cynthia and I did. So basically, she did a presentation at a educators conference on reductions. And I said, Cynthia, you are right where, like, why haven't we been talking about this? This is exactly what I've been talking about with students and trying to figure out who's doing this stuff. And she goes, you know, what we really don't know is what's happening in practice, what people are doing right now. So we said, we better get on this right now and do it. So it was published in the JT last year. And the interesting things of it, I just summarized here kind of from the abstract, and I won't spend a ton of time with this again on techniques. But the thing that's going to be important on this is for her and I or somebody to do this study in a few more years, 5 or 10 years, and see where we are. Because up to right now, we're in this kind of middle group where those of us that are older were taught not to do reductions, right? And then some of us still did. A lot of us still did, actually. And then the newer generation is coming up where it's actually in one of the things that's in the educational competencies to look at doing. And so now the techniques are being taught and will probably be performed more, I think. I don't know. And then the other thing, so that's kind of the first kind of 3 kind of points there, along with the joints that were mostly done, which is the common ones that we do. And then the thing on the bottom that I'm going to spend a little bit of time with is having standing orders. So we need to talk about that here in a second. So I'll look at the laws. So can we reduce or not? I don't know. Look at your licensure law, look at your scope of practice, and talk to your physicians. This bottom quote right there is directly from the position statement, right? Directing our physicians. And it was really interesting. So I love skiing. Like was said, I love outdoors and I love skiing. And so I go to this meeting that Randy Cohen and Denny Miller put on in Big Sky, Montana. Gives me another excuse to be outside. Okay, we meet, we ski, we meet. So it's, you know. And I was on a panel this year with all physicians. Everybody else was physicians. So I got up and said right away, well, I'm also Dr. Diede, but I'm the preaching kind, not the practicing kind. And they all kind of got a kick out of that, and we talked and so forth. And I said, I'd like to hear from the panel, because that's one of the really nice things about that meeting. We stand there and talk to the physicians, and then you can meet them after. You might ride up the lift with them and so forth, and ski with them for a while, and you just can talk it out. And one of the things they talk about, all of them, except, and I'll get to this in a second, the ones that are always the most cautious. You know, you think about all the big joints that you talk about, the elbow, even the talar crural joint that's not mentioned well it's not mentioned other than, hey, maybe don't on that one in the position statement, or it was the hand guy, right? Our hand physicians, when they have to put on microscopes to see what they're working on, they don't want us pulling things around and breaking things, right? So he was the one, right, be really careful, but I loved how you talked about it, so be really careful about interposition of tissues and so forth. I'll get to in a second. But our physicians are willing to do this for us. Now, I don't know about standing or even written orders, but they're willing to have us do this for the most part, right? Now, we have to build that relationship and have that with them, so forth. All right, let me talk about just a few things. So I started with New Mexico and went all the way through. Again, not very much time with this, but I did want to talk about that. I read the laws. I didn't go through every rule and regulation in every state, but I did talk about or look up a couple things that would allow us to do this or not. I was looking for things that would not allow us to do this, and what our license laws in our district say about orders, right? And New Mexico has this language on there about written order and protocol from a licensed physician, right? They also we have to have those things of that's one of all of our laws in our district that talks about emergency care, probably the strongest here in New Mexico, right? and as long as it's within the scope of practice, and again, written athletic training service plans here in New Mexico, right? So have those. Arizona has, and I cut through some of this obviously, so it's not all the rule there, but they don't have anything about a directing physician in the law, but it's within a board rule. And that board rule is the bottom part there that talks about written protocols. So those of you in Arizona need to have that. This would fall under that, right? Especially when the position statement on every joint except the elbow says, under the direction of a physician. It literally starts with that phrase, every single one of them. Colorado has, and I put just cut a little piece of it from about what would qualify us. It doesn't have anything about first aid or really emergency evaluation, but under management and treatment would go under there. And oops, did I forward that? Yeah, thank you. And interesting to Colorado, and you guys can tell me, again, I may have missed it somewhere, but I found nothing about supervision in the Colorado law except for if you're not in an athletic setting. That's the only time that you need supervision, technically. So go Colorado. Do it on your own, I guess, right? And then Utah has again, written or standing orders, service plans, protocols as well. And then we don't have anything specific for emergency care, but kind of immediate care of athletic training injuries. Okay, oops, I think I skipped one. Oh yeah, Wyoming. Don't forget Wyoming. Wyoming has also medical emergencies mentioned in there, immediate care medical emergencies, and they have probably the most direct language about supervision for all of their services. So in Wyoming, it says supervision agreement, written, and needs to be turned in, apparently, right? So I'd love to talk to you in Wyoming about doing that. All right, so can you do it? Yeah, I think there's language within the licensure laws, but it's always with that caveat of having discussions with your physicians about that. So the question is why reduce and why wait? And there may be reasons to do that. That's the longer part written in the position statement. For me, it's always been, number one, I don't like having my vomit on my shoes. And it seemed like the longer that I left athletes with a dislocation, especially once they saw it, that my shoes were going to be damaged. And so right away I was like, well, I guess let's put this back in before that occurs. And so that's kind of where I came at it from. There's immediate relief, right? Now, that doesn't mean there can be secondary injuries that will occur because of these. We have to watch out for those, and I'll talk about some of those as I kind of get through this. Again, I am not saying, I want you to make sure to hear this, I'm not saying everyone needs to walk out of here and next week go to your doctor and say, hey, I need to reduce everything. And I'll talk about, if I have a little bit of time, I'll talk about the training in that area just a little bit. So it's hard. It's hard to get training. Other than maybe showing up at an emergency department and waiting for something to come in, there's not that many opportunities for these to really practice. There are some training devices and so forth out there. Okay, I'm going to go over the procedures here just a little bit. Okay, so this decision tree comes from Cynthia Wright in her article that was a year or two ago now. And I'm sorry you can't see that very well. Or maybe, yeah, you probably can't see that very well. And these will be available. So the main thing you have to decide is when are you going to reduce and when are you not? And most of the time it's a matter of, is there something comorbid to the injury that's going to occur that's going to cause further injury, right? Or you're going to cause more damage, or there's already damage in the area that's going to make reduction impossible, right? So I won't go through this anymore other than to say, generally we're thinking about vascular and neurological, but that's not a hard stop, right? It's not necessarily a hard stop. We can go ahead and give, and this is the thing you have to talk about with your physician, is how many tries are they going to give you? The position statement was pretty conservative in saying, well, give one good try. Right? Most of your doctors will say, well, what, and you need to have the conversation with your doctor, what does that mean? That means, were you ready? Were they all sweaty and so you slipped and or whatever, or they jumped? What does that mean? Or can you try a couple different techniques once and determine mechanical disadvantage there? All right, so let's talk about 3 quick ones. I know I don't have very much time left, so I'll talk about these real quick. A couple of these I literally have one or just a couple of slides on these. Talk about the techniques, and we'll talk about some specific ones later. Finger, the patellofemoral, and the shoulder. Thank you. Oh, and then the less common ones, if we have time, which I don't think we will, we'll talk about some of these just a little bit. Right, patella. The easiest one to do, right? Well, not the easiest to do, rather mechanically probably the easiest to do. If you can get that quadriceps to retract, to stop contracting, to just relax, right? Where's Kevin? Get him to stop cramping. Okay, so get him to stop cramping, relax. You usually can fly that right over with minimal pressure, right? The other big thing about all of these techniques is always use the one that's the most gentle. Always be gentle. And my students always tease me because I see how hairy I am. I'm a gorilla everywhere. So, and plus I have big hands, so they say, well, we can't do it like you. You're just a big gorilla. I say, well, in this case, I need to be soft. You need to be soft, right? As soft as you can, delicate, massaging, work it out. So that one's really easy, almost always lateral dislocation, going medial. If you can help go from flexion to extension just a little bit, yes, support it. You'll see several videos online where the emergency department people, sorry, I shouldn't laugh, but people are in pain, but they just yank it, right? They just take their leg, put it completely into extension, and slam that thing over. Secondary injury can occur, so it's one we have to be careful of, just kind of jamming it back in. All right. Fingers. So let's spend a little bit of time with this. Dorsal or volar. Let me go right on to the volar plate. I have some frequency things on there, and then, of course, valgus or varus dislocations you have as well. Dorsal probably most common, then volar, then lateral. And then volar plate. So I want to spend just a second on this because this is probably the key thing from the finger besides the technique. Again, I mentioned those doctors that I talked with up at Big Sky. They said volar plate is one, besides the extensor mechanism, number 2, that we've got to be the most careful about, right? We've got to be careful of that. So this is the best picture I found. I think this is from that Roberts and Hedges book, that big red one, and it's thick too. That book is about this big, huge book with lots of techniques in it. That's the thing that's going to have interposition into the joint the most, that would cause us problems. So when we have a technique, either of these techniques that we use by just traction or exaggeration, and it's not going in, stop. Stop. Because you probably have the volar plate or some other tissue in there that's blocking it, right? So what's going to happen is you crank it really hard, you get it back into place, but the volar plate is now folded in the wrong position, and they're going to have to go in and get that back and put back in the right place anyway, right? So I skipped over all that stuff about x-rays pre and post. That's definitely something that you want to do as well. Okay, so 2 techniques. Traction method is just pull it, right? And it'll slide, those 2 congruent will go right, surfaces will go right over each other. Again, with relaxation, with trying to calm them down, with probably taking it out of their view, several things you can do that way to help with that. The other one, I didn't know this method. I've used it before I knew what this was called. I came upon it by accident, and then I didn't know the literature of it until later in my career, is exaggeration method. And it's counterintuitive to take a joint that's out of position and move it toward the position more, right? But it anatomically makes sense if you're going to exaggerate the joint out of position. In other words, those condyle surfaces are not against each other, and now we have to exaggerate just a little bit more so we can get to slip down and slide into place, and then we'll have a much better effort at getting that back in. So that's called the exaggeration method. All right. Questions on those? So I know I went kind of fast about that one. There's just 2, patellar, simple one, fingers, two techniques, generally speaking. Stop if it's blocked, right? And again, I skipped over the evaluation. We all know that, evaluate, find all the anatomy. So let's talk about a few of the shoulder techniques and why we would or wouldn't do these. Anterior dislocations, yes. Posterior, no. Right? If you're palpating the humeral head And Aaron will make fun of me because I say humeral head all the time, because I'm the lower guy, he's the upper guy, and I say humeral. So if I say humeral and we're talking about the shoulder, I mean femoral, I mean humeral. See, I get it mixed up. If it's posterior, no. The likelihood of already having a fracture there is really high, and the process of putting it back in is really difficult. I mean, if you can get somebody to relax, you might have a fighting chance at it, but you're going all the way around that scapula to get the humerus back in, it's really difficult, right? Anesthesia is going to be their best friend for that, right? So that's what we're talking about there. So here's all the techniques, which means whenever I see a table like this, I say, look at all the fun techniques, kind of what Jim was talking about before, all the different techniques to do a test. There's probably not any one good one, right? And that's kind of our problem with shoulder techniques, and I don't have enough time to spend any time with mentioning any of those. 40 plus, lots of them. We'll review just a couple here. All right. Oh, the other thing that you really want to be aware of, and this is the most graphic Hill-Sachs lesion ever. You can see that one of the big comorbidities that we talk about on the shoulder, on relocation, the initial dislocation or the relocation is Hill-Sachs, right? And the question is, if we don't get pre and post x-rays, we don't know which did it. Did it happen as part of the dislocation, or did it happen as part of our attempted and possibly failed reduction technique, right? So that's another one we'll do. All right, so let's just a couple techniques. And I was interested in the guys that did the action sports talk downstairs yesterday had mentioned on the shoulder specifically that they were there, athletic trainer, PT, medical doctor, and I think it was in a motorsport accident, right, where they fly way up in the air and so forth, and they bypassed all those people and had a fellow athlete or somebody they knew come and relocate their shoulder, right? So, and I'm okay with that. We ought to be, on a first-time person, they're going to be a lot of trauma. They don't know what's going on. We're going to find a technique for them. Somebody that often dislocates, they may tell you, hey, just do this. This is what they may literally talk to you and say, hey, just pull it like this, or I need to get my arm out over here, and I think it'll go back. So be willing to talk to them about that and work with them and not just go to a technique that you've practiced and learned and so forth, if you can communicate with them. This is one that is a self-reduction technique, right? And no reference to movies and slamming yourself into walls or whatever, right? But so there's only one really, besides the person trying to grab onto something and do a distraction technique themselves. And this is called Davos. I learned it as Davos, but it's also called Boss-Halzak matter maneuver, right? And there's a couple different things you can do. They just either hold on and lean back and try and pull that anteriorly. There's another picture here. Can you get that to go? I'm not getting that to go. Thank you. Where they actually put the hands together, right? We strap the hands together, and so they don't have to worry about the squeeze with their hands that way. The trick with this is it takes time. And most of us are not patient enough to say, hey, so just stay in that position maybe 10 minutes. I don't know, 8 to 10 minutes. I mean, how many of us are going to do that? I mean, it kind of make us nervous just to stand there while they're in pain, trying to put it back, and we can't do anything except, I love this picture, that kind of help put the table down for them. There you go, that's my help. That's my contribution to this technique, right? But it might work, and they might know that, and they might have been a frequent dislocator, so they've done that. All right, I've got to go through a couple of these a little bit faster. This is probably the one I use the most, and probably you see the most common, dislocation or external rotation of an anterior glenohumeral dislocation. And probably most commonly in my practice, before I became an educator and don't practice as much as I used to, is I would even do this sitting or standing. Right? Now, even on little football players or little freshmen, I can think of, just by doing the evaluation, sticking your hand in there, supporting their arm, externally rotating just a little bit, maybe bringing it a little bit abduction, it'll go right back in, right? Somebody's a little thicker, muscle guarding already, you can do that nice and easy. Just easy dislocation, and then you add just a little bit of distraction to it. Here's another picture of that one. I'll skip over that one for now. Spazo technique, there's variations in the literature about this one. This one's come from the Dannenbaum group, who put out some pictures and so forth about it. So it's a traction, and if you can get their arm into that flex position, then you provide the traction there, and then try to do the rotation, right? In other words, that glenoid fossa, we're trying to get the humerus to just crawl back in, right? Gently crawl back in there. So that's spazo technique. Traction, counter traction, you need 2 people to do that. And so the nice thing about that is you look at the picture on the bottom there, and somebody has, you know, use a strap or TheraBand or whatever you might have that's tension enough to put some traction through the arm there. Here they're using a sheet. This is actually a picture from the book, but it's also has a video on it as well. That will help you with the rotation. You don't have to do the traction. You can control the rotation, the practitioner that's on the arm right there, right? Fares, I'll skip over. Oh, no, the one thing on this one. So on all of these, because there's not a great single technique on these, you can add a couple things to each of them. Fares is one where you kind of combine some things together. The thing that I haven't tried, I have not tried this in practice, so full disclosure about that, but it makes sense to me. I wouldn't do it as this distal as this practitioner is, but you could do some oscillations. The idea of this technique is to do a little bit of oscillation back and forth on that humeral head until you can get it to, again, crawl safely into the fossa there. All right, scapular manipulation. This is, again, a technique that you could use if you have somebody to help you with almost any of these other techniques, right? So the idea is you do external rotation with scapular manipulation. I mean, obviously you'd have to have them sitting or a sideline, spazo, same thing. So you're going to take the scapula and you're going to try and turn it down so it can meet the humerus. Right, again, and I think if you look at some videos where they're doing this, it seems like the biggest part of this is they just got the person to relax, right? That I think just putting hands on the person and getting them to calm down kind of help with that technique. All right, best of both is, again, so it's a combination of those 2 together. You have the distraction, kind of a sitting external rotation technique, pulling down. I know the picture is kind of weird on the angle right there. And then you have a second practitioner doing the manipulation or the down turn of that humeral fossa to meet the humerus. Okay, Mills technique, I put this in here because, again, you need to find the anatomy, you need to find where everything is, and if you can grab on as best you can to that humeral head, that's great. All right, keep going. Simpson maneuver, this is probably an old standby, right? And again, this takes time to do that with the weight on the shoulder, get them to relax in that way. And this seems counterintuitive to do this toward an anterior dislocation, but the idea is you're overcoming all those rotator cuff muscles and getting the shoulder to relax, and then it just slowly crawls itself right back in. Go ahead. All right, a couple that we shouldn't do. I still have doctors that talk about these techniques, like, oh yeah, just stick your foot in their axilla and yank on that puppy, it'll go right back in. All right, gentle technique first. If you're out in the woods and nothing else works, then maybe one of these 2 techniques that are more violent, right? Hippocratic is the first one. Eskimo is the second one, where you literally lift up the person and drop them down, full body weight, right? Drop them down. So let's not, not really do that. All right, let's talk about a couple of these, and I know I don't have a lot of time, so I'll kind of go a little bit faster these, and including maybe park on the elbow just a little bit more, because it's a little bit more controversial one. Femoral acetabular, so the hip, there are, again, all these different techniques. Not all of these are described in that Roberts and Hedges book. Several of them are, and I have a couple pictures of that. It's actually not a terribly complicated procedure, right? We have a ball and socket joint that's out. Again, anterior is the one we're looking at mostly here, although you can work with it. You'd want to get an x-ray if you can on these. The problems with the vascular issues close to the hip are hard to detect, right? We're talking about circumflex vessels here, right? So those are really hard to detect. So most of our physicians will say, yeah, we want this in as fast as you can. Now that doesn't say that we'll have labrum, we have ligamentum teres, we have a bunch of things that can kind of be problematic, but we want to get these in as fast as we can. So let me show you just a couple of pictures of these. This hard, it takes a long time, and most people and most of our athletes, they work on those glutes, and they're gonna be all locked up. And so if we can't get them to relax, that's gonna be really hard to do. But mostly it's a traction technique. They're traction techniques, or they're a cantilevering, kind of that Whistler technique is a cantilevering technique. That Captain Morgan technique is with somebody's knee. You usually crawl on the table even more than that. And you just gotta yank it, right? This one is less gentle because of the full-on weight of the limb and trying to put that back in, right? So we have a couple good techniques there. Right, Taylor curl, how am I doing on time? Almost out, all right. So Taylor curl, just one thing on this. This is the one not mentioned, well, it's mentioned but has no technique, no precautions, whatever, in the position statement. It's kind of like, just don't do it. In rural Utah, I've seen this done. So one of my other jobs that I do just for fun is run around fields in Utah and watch football players play, and I throw my yellow hanky out there, right? And so in rural Utah, this has happened, and it's been reduced. Actually, I saw one of these get reduced on, it was rural Utah fields, but on Weber State's field, right? Coach came out, oh, it's out, whatever, oh, well, let's jerk it back in, right? And he did. So, but the problem with this one is you're gonna have a fracture, all right? Let me move on. So there's a couple techniques, and the slides are in here and so forth. Let me talk about this one, and this is gonna be all the time I have. Let me talk about this one. There's contradiction in the position statement regarding the elbow. There's two different statements in the position statement. One talks about, hey, don't do it unless there's, don't do it if there are neurological symptoms. And the other place says, well, you really need to consider doing it if there's neurological symptoms, right? Because we want to get it back in. Now, the technique here, I mean, so the question for me, for you is, would you do it? Here it is. And again, this is a posterior, on this one, it's a posterior technique. An anterior technique is much harder, probably going to have electron process completely gone. So you kind of have to judge that. Would you put that bit back in or not? It's a pretty easy traction and, distal pressure and traction technique. It's not that hard. What we worry about on these is potential interposition again of mostly the ulnar nerve, right? The chance of that, though, is really low. The true probability of that is low. Now, that's emergency room data, and maybe they do it under anesthesia, and there's some things we need to do in athletic training, but it's probably pretty low, right? The ability to save the tissues that are neurologically impaired because of the dislocation and the vascular compromise that's in place because of the dislocation, much like the hip, is probably a better result if we can get that in sooner than later, right? So you need to practice these techniques with your doctors, talk about them, a little physically do them. Like I said, I'll just mention real quick, there are a couple models out there, Sawbones. I just bought one, a shoulder and an elbow one from Sawbones. They're not awesome, so I'm not advertising for them or whatever. But there are some models that we can kind of try things with. And then it's just a matter of pulling on normal anatomy and kind of finding where things go on each of these joints to get them to go back together. So with that, I think I'm out of time. I'll see if you have any questions. Aaron.
Is this on? Yeah, our office is 100 yards apart, but we'll travel a few hundred miles to ask questions about this. So sorry, but I did have a question. So one of the things I use, like the phrase, and I'm glad you said camping, because or like out in the woods, because that's the phrase that I'll use with students. I'll say, hey, if you're off camping and this happens, it's okay, but if you're on the field, it's a little bit different. When you talked about a physician, or what was the phrase, under the
direction or
proficient or
supervision.
something, the physician, if the physician basically kind of says, hey, I trust you, we've built a relationship, do you think that's okay? Like, are you okay doing that? Would that qualify, or do you think they have to be right there? You know what I mean?
No, yeah, I think that counts, yeah. And under these, that's why I know I went quickly through that stuff, but there is the mention of verbal, right? Of verbal orders when they're not there, right? They're directing when they're there, so obviously you wouldn't just, a dislocation, go over, your doc stand right there, hey, just go for it, right? You'd turn to them and say, doc, are we okay? We're trying this technique. Are you doing it? I'm doing it. What's going on, right? Mostly what I'm talking about is when you're not there, when they're not there. The physician's not there to supervise you. What is a protocol allowing us, the athletic trainer, to do it? And verbal's fine. Now, it's fine, but not recommended, right? Let me be clear on this, so thank you, Aaron. You want it written, right? You want it written. And like I said, whatever, forget now the states that have it, that you need, Wyoming, for one, you need to have written orders, right? So have those in place, talk about the specific techniques, talk about the time. Now, the other thing I'll say is the physicians will get a little uncomfortable with that, right? It's their liability now. So you got to understand that. You're working under them. But for the most part, once they figure out what you can do and can't do, and you talk about techniques that maybe you've done in the past, if you haven't done any yet, you just tell them, I haven't done this yet. I've never done it. And they'll usually say, okay, well, let's talk through a couple techniques. How would you go about it? Something's happening. Sometimes you can get them on the phone, that kind of thing. Yeah. So, but yeah, I'm not telling you run out and do it. Run out and tell your physician, hey, we've got to let me do this. I mean, it's a conversation, but I think our physicians are ready to have it.
I think it's a conversation we should have, though. Absolutely, right? I mean,
Yeah, absolutely. Yeah. Anything else? Anybody? I know everyone's ready to go. So I don't blame you.
So in general, like what would you say is the max amount of times you should try to relocate something before you should just stop and refer? Like is it like a one and done thing, or does it just depend?
So you want position statement or you want Mike Diede?
Either one.
So position statement is really one, right? So the position statement is one good technique, right? My opinion is one good technique until that one fails, and then try another one. Right? I mean, because maybe you didn't pick the right technique. I'll give you a perfect example. Wrestling kid, Lisa may remember this. Wrestling kid on the mat, right? Timing, trying to get back in. He doesn't want to be disqualified. Lisa's trying to get back in, can't quite get it. I can't get it back in. I go ahead and just do a traction technique, and then I kind of try it for exaggeration. And I'm like, what's wrong with this kid? He's like all oily, like not just sweaty. He's like, did you use lotion or something? Like, what's the deal? So I had to take a second, go get a glove, right? I went and got a glove, and I didn't even put it on. I just took the glove, kind of put my finger through a side of it, grabbed it on so I had enough traction, and so I did it. And then I got it easily. But I was just slipping. I wasn't able to get it. So I would say if there's an error in the technique, it doesn't count. That's it. But talk to your physician about that. My physicians in Tucson and then the ones I've talked to in Utah were like, well, I don't know why you wouldn't try like kind of 3 times. Like first one is they screamed and that freaked you out, right? Second one, you tried it and you slipped. Third one, you got it, right? So they're kind of a little more open to give some tries, right? So I want to stay with the position statement, but I'm going to say you talk to your physician about that and get that settled. Does that help you?
Yeah, thank you.
Okay, good. Go ahead.
When you go to document relocation, would you document number of attempts?
Yes.
Or just attempted relocation?
No, number of times, and I would even be as specific as you can about what you tried. Right, because especially with that hand doctor is going to want to know, well, which was it? Was it volar or dorsal? And then what did you kind of try? So when I'm going back in there or looking at the MRI, we can say, you know, and it will protect you in the sense where, well, I didn't put that volar plate out. It was out, right? And I tried the technique and it didn't work, and this is why I referred it. Does that help you? Yeah, so I document if somebody can keep time of it, what you did, and the number of techniques and what the techniques were, or some description. You know, like with Jim, I don't know about names of special tests and all that stuff. We try to get these down so we know what we're doing. Right? That's why it's important to have the names to have this discussion. Kevin.
Mike, anything on return to play timelines if you wait and splint?
Yeah,
versus...
I skipped. Yeah, so I skipped way all over that, but I'll say this now. Thanks, Kevin. The position statement, and this is my opinion as now not the guy standing on the field so much, these techniques are not meant for return to play, right? But I know you're all looking at me, but we just saw this football season, Notre Dame, on the Notre Dame network, right? Everyone saw it. Boom, pop back in, go back in, throw a touchdown, right? So I'm coming from the perspective of we should, and the position statement backs me up on this, is pack it up, refer it, get x-rays, all that kind of good stuff, right? If your question is like, well, how long does it take to recover from these? Is that more what you're asking?
Right, so if you reduce on site and potentially cause other injury, is there
Yeah.
any data about return to play prognosis-wise versus if you shift right away and a physician does it in the ER?
Yeah, no, we don't really have that data. We don't really have that data yet. I mean, because most of the data that comes from dislocations, and we have some athletic data from that, but even because of our protocols in the past, they've all end up in the emergency department. So our timelines are from emergency department on, and then usually, if it includes a surgery, then it's surgery recovery time. Yeah. So we need to do, once we start doing these and have our protocols down, talking to our doctors, we do need to document these, right? Just for our protection and then to do research in these later. Yeah. So. All right. Thank you. What's the score of the game? Like anybody checking? I'm glad you stayed with me during the Final Four game. This is amazing. Thank you.